Dear pure urologists, good evening, one and all. Today is a special occasion that it is 399th session. The session will be 400th, and this is as precious that 399th session. Pure Urology has served the needy juniors during Corona time, and we continued this trend after the Corona because I was happy conducting occasionally 5 p.m. sessions, and lot of surgeons across the world have shared their knowledge, and slowly it became a video library. So this time we are talking about laparoscopic pyeloplasty. Next 400th, we are including a debate with RIRS and PCNL surgeons, four seniors PCNL like S.K. Paul, Ravindra Sabnis, Madhusudan Agarwal, and Khadgi from Sanjay Khadgi from Nepal. Whereas RIRS we are involving Dr. Kandar Parikh, Dr. Anil Shrestha, Dr. Nanjappa, and Dr. Vineet Gauhar. So we will have a debate that will be 400 on the date 29th, that is Wednesday, 5 p.m. Regarding the today's talk, honestly, Dr. Sagar Bhalerao is my close friend. We have worked together in his hospital, and we have been close friends for quite period of time. He worked hard himself and came up with all these skills like transplant, laparoscopy, endourology. Pyeloplasty particularly, whenever we are learning laparoscopy, nephrectomy is easy. And sometimes any destructive surgery easy. Once people start doing nephrectomy, they look for pyeloplasty. Initially, cases will come, lot of time it takes. Then you may have 1 or 2 leaks also. Then the spatulation of the ureter takes lot of time. Orientation is a problem. Suturing takes lots of time. Urine will be leaking. You will be doing suction, and liver will be falling. The colon mobilization may be inadequate on the left side. So many issues will be there. To discuss about that, he will be talking about the basics so that how to do the pyeloplasty. Before going for this thing, I am sharing his why it is two things are coming. Why there are three? Why three? So the topic today is my journey of learning laparoscopic pyeloplasty by Dr. Sagar Bhalerao. He is MS, MCH, DNB, consultant urologist at Bhalerao Clinics, Baner, Pune. That is his main working area. Currently associated with Jupiter Hospital, Symbiosis Medical College, and several leading hospitals in Pune. Served as assistant professor of urology at BJ Government Medical College and Sashan General Hospital, Pune. Alumnus of Lokmanya Tilak Municipal Medical College, Lokmanya Tilak Municipal General Hospital, it is called Sayan Hospital, Mumbai. Recipient of Dhanvantari Puraskar for Excellence in Urology and the Best Surgical Video Award at West Zone Urology Conference. Lead renal transplant at Symbiosis Medical College, where he established the laparoscopic donor nephrectomy program. Special interests include laparoscopic urology, robotic urology, endourology, renal transplantation, and minimally invasive urological surgery. Author of multiple peer-reviewed publications, actively involved in clinical research, including the International POISE 3 trial as co-principal investigator. With this introduction, I thank Dr. Sagar for accepting this invitation. Over to you, Dr. Sagar, please.
Thank you. Thank you very much, sir. So today's talk is mostly how I started my pyeloplasty when I was knowing nothing, and how it now I'm doing very complex and difficult and even robotic pyeloplasty. So how the journey progressed. So I want to give a generalized presentation so that you can also, even whoever the newest urologist will have a confidence, yes, if Dr. Sagar can do it in this way, then I can also do it. And it will just give a roadblock of what achievements you should do before pyeloplasty, how you should go ahead about it. And ultimately, once you practice, the success will be yours. So without wasting much of the time, I thank you, Vadi sir, for this opportunity, so that many people are learning from this pure urology. And as the name stands, it is just pure urology and nothing else. So the techniques, the principles, these are purely urological, and I thank sir for this opportunity, as well as congratulate him that today is the 399 session. So almost 1 hour each session. So many 400 hours of data is there. Any people can come anytime on online whenever they have time, and they can have an video presentation and enhance their skills as well as their theoretical knowledge. Thank you very much, sir.
Thank you.
So with this, I will start my
Yeah.
presentation.
Yeah.
So today is I will discuss about my journey of pyeloplasty. So the aims and objectives is to generate interest in laparoscopic and robotic pyeloplasty in urologists. So most of the urologists are usually trained in endourology. There are very few centers in India. They do laparoscopic training, and many people in their surgery training are also not that much given. And even after one entrance exam, they are studious, they get the urology, but प्रॉब्लम इज दैट कि वंस दे आर यूरोलॉजिस्ट, दे आर एक्सपेक्टेड कि अगर इसको लैप नेफ्रेक्टोमी तो आता ही है, अरे इसको तो सब यूरोलॉजिस्ट आता ही है. बट प्रॉब्लम इज दैट द एबिलिटी, एज सर सेड, द एबिलेटिव सर्जरीज आर इजी. यू डू नेफ्रेक्टोमी, you do any excision, that is easy. But whenever there is a suturing and reconstruction, that is the difficult part. And all urological surgeries are advanced surgeries, because these are all retroperitoneal structures, and the tissue differentiation has to be maintained. So I am in touch with many urologists in Pune, and they are in different stages. And the most difficult step they tell in a nephrectomy is not about the vessels or dissection of vessels, because they have done it many times, but it is about separating the colon from the retroperitoneum. Many a times that plane is gone. Somewhere you sometimes you go behind that gyrotas fascia, somewhere the colonic vessel is injured. So staying in that perfect avascular plane and learning that plane takes around 50-20 colon reflections on a regular basis, so that you can understand. Now about ablative. Whenever you come for pyeloplasty, the
Your
many
slides
people,
are not moving.
no, it's not moving. So I am not moving in.
Okay, okay.
Uh-huh. So the thing is that ki whenever you do nephrectomy, you get a confidence about pyeloplasty. Okay, I can do it. But once the suturing part comes and the struggle starts, then अरे नहीं छोड़ा, अभी open करके कर देते हैं. ऐसा lot of times many people have. But let me tell you, there is a way, and you can do it, and your first pyeloplasty will be absolutely easy. So I was trained in Sion, where there were a lot of open surgeries. There was only exposure to laparoscopic cholecystectomy and appendicectomy during the surgery residency. But that gave me a good idea about how to handle laparoscopic instruments for these ablative surgeries. And doing the dissection, I was already used to it when I was giving. And I was got interested in laparoscopy when I was exposed to laparoscopic training in Mumbai. This is one of the photographs of me with APJ Abdul Kalam sir, where I was attached. I was regularly going to one of the centers for my learning, that is Johnson and Johnson Center. Star Center is there, Sentry there, where these laparoscopy 3D cameras are there, so you can learn. And for inauguration of one of the centers, Kalam sir came, and I got the opportunity to show my laparoscopy skills for on a pig model which is kept under the trainer. So the trainer helped me a lot, a lot. So everybody who is starting laparoscopy, first use, these is all new instruments. All the movements are continuous. In your hand, when you move your hand to the right, everything moves to the right. But in laparoscopy, you move your hand to the right, everything moves to the left. So these are counterintuitive movements. You need to get used to it. You need to get the scale used to it. So, and that is why the trainer helps in this thing. And basically, there are different exercises which I can show you. So look at these exercises. So this is a beat exercise in which you can transfer the, you can use this trainer. you can put some beads or some any instruments, and you can with right and once with left balance the thing on different rods. Or there are different beads also where you can take this bead into one hand and transfer it into your another hand and then keep it. Then if there are such rods are not there, then you can keep it in the different petri dish. There are certain beads with holes are there, so you can thread those beads onto a thin fine needle to a straight needle, which is any tailor needle which you can get, so that you get used to your instrumentation and fine finesse of the surgery. And finesse of the skills is very important, because a surgeon, when he becomes an MCH urologist, he already knows how to do surgery, he is already knowing the planes, but only thing is that doing whatever his brain thinks inside the abdomen is important. It also helps you the orientation of different things. Now let us let us learn about this. Whenever you are going for pyeloplasty, handling of suture and needle is the most important thing which you should do. Otherwise, this step will lose your confidence. If you don't know this, if you are not able to do this, you will have a lot of frustration and go. So these are different. One of the exercises is holding the needle, rotating the needle around the axis like this, so that you can get the orientation. So there are different points available on the needle. This is a point which is two-third from the tip, two-third away from the tip, where you can hold and get that thing. Also, while I will show you one more exercises like throwing a stitch. So these are basic steps where whenever you take a stitch like this, hold the tissue. You should get the feel of the tissue, so that your 3D orientation in a 2D environment is good. Most of the laparoscopies today are 2D. However, you now are getting 3D, but these are costly thing. Basic principles: once you throw the needle, this drop the needle, this U of the suture which you see should be quite long enough, this U, so that, and the angle in between the thread and this one, this angle should be is very important, so that your suture moves around the another instrument like very easy. So you can see that it is very easy if the angles are proper. However, if the thread is parallel to the instrument, it becomes very difficult to throw a knot here. So this is a perfect flat knot you can see here. Now, once this is done, then for the another knot, again make this U and then throw it in the reverse pattern and then hold this suture. And these practicing skills are very important, because this is for simple suturing. Similarly, you can go for continuous suturing practice. And these skills of holding the thread, holding the needle, rotating the needle around the instruments, tying the knot, these have to be absolutely practiced before you do your first pyeloplasty. So if you see, this is all circular. So in a pyeloplasty, you have to rotate all 360 degrees. So you need to practice all these skills by suturing the whole 360 degrees, or at least start with 180 degrees, then go for another 360 degrees, 180 degrees, so that all your skills are quite well. So whenever the suture is very small, so this all technique will help. You hold the needle and rotate the needle hub around that instrument and then tie a knot. So this handling the small sutures, handling large sutures will have more problem, because again you keep on tracing that suture and it will be difficult in a laparoscopy. So in a laparoscopy, the ideal suture length is around 15 to 20 centimeter. If it is too long, again for continuous suture you will have problem. If it is too short, at the end of the suture you will have this kind of small suture problems. So these different tips and tricks definitely help you. So always practice your throw. And how to rotate the needle, then the elongated U of this suture for suturing of this for tying a knot is important. So see what will happen if the U is small, your angle is bad, you will not be able to properly take a suture. And this is the common thing which happens when somebody tries a pyeloplasty for the first or second time without doing all this practice. So you should practice on your own. These are simple tricks, and these are usually unconscious mind. Once you do this open surgery, these are just unconscious. But when you are doing laparoscopic surgery, you need to be conscious ki where is the U, where is the suture landing, how much is the angle, how is the angle, is how the suture will be easy, and that you will understand only when you are doing regular practice of all these suturing. See, if the needle is in the opposite side, simply not able to take the suture. But when the needle hub turns towards the angle, immediately the suture will happen. It will be easy. So see how the angle is there. So if the angle in between the tissue and needle is not good, then this needle coming out direction will always be wrong. So you should also practice movement of both the arms together, so that the whenever you do suturing, the suture does not come out. So good luck. And important thing is, just remember, practice is very important for before doing any first pyeloplasty. So my first lab pyeloplasty was not on a human; it was on a chicken. So if you see the suturing model, so before doing suturing, you should always use a glove. Cut the finger of the glove and pin both the ends and try to suture first on the 360 degrees about how you are willing to do. And once you do that, then there was a program in Nadiad where advanced training laparoscopy, where it was a 2 days program, in which first day they trained us in the console, and second day they gave us a chicken esophagus pyeloplasty model. So what is this? What a chicken esophagus and crop, that is called as a additional stomach is there. So that it has a very similar tissue consistency like puja. So this is how a chicken is prepared. A whole chicken is brought. You'll hardly get it in 200-300 rupees in the market shop. There is no any animal problem, what we call as Priyanka Gandhi will not trouble you in this situation because you already eat chicken. And you just bring this chicken, you wash the crop, you put a infant feeding tube it, you tie it up, and fill this additional stomach called crop. And you can see that this all dissection of the tissues separating the pelvis and the stomach, all these have a very real tissue consistency. So that before trying your pyeloplasty, if you do this and are successfully able to suture this, then 100% you will be able to do. So you can see that this is the esophagus, which is quite distended due to the infant feeding tube, and this is the additional stomach called as crop in the chicken. And you separate all the fat and tissue without injuring the pelvis, so you get a hang of how the actual tissues and stretchability of the tissues will be there. You get the feel of your instruments, how much stretch you have to apply, how much pull if you make, then tissues will break, because this feel is very important without damaging the uh, structure. If you are able to do this anastomosis in a very well pattern, then definitely you are eligible to do any pyeloplasty in an human person. And I would strongly recommend this because uh, many people, conversion to open is always an option. However, when you say to the patient, okay, I will do it laparoscopically and don't worry about open, then that the level of confidence is already seen on your face. So if somebody new is there, is always tell ki no, there is a 5% or 20% chance ki it will this have to do it open because these are difficult surgeries. While a confident surgeon will be able to do, oh, hardly it is 2 or 3% chance ki we have to do it open. Otherwise, 99% or 95% chance we will be able to do it laparoscopically. So you see how this additional stitch you can take for holding the thing, then you can it will have a similar feel. Once you do the cutting of that stomach, immediately urine kind of whatever filled you have filled will come out, and it will collapse like in a actual pelvis. And you can see the first stitch, how to take. You can plan everything so that you will be able to do it. So this is how a chicken pyeloplasty model is done, and a stretchability of the tissues, the leaving of the this should not come out, then taking the stitch, holding it, all the knots outside, and suturing. So my first pyeloplasty, what happened? I thought, कि, okay, this is very easy. So I got and I sutured the anterior layer to the posterior layer of the esophagus. Then अरे ये कैसा हो गया, उल्टा हो गया सब. So then I have to cut everything back, and then again everything I have to suture. I thank God कि okay, this chicken gave me a chance. कि had this happened in an original pyeloplasty for my first time, it would have been very difficult. So I will always try to make sure कि whenever there is a pyeloplasty, I suture the proper layers with the proper thing. Otherwise, you have to completely, you should see the twist of the ureter. It should not get rotated, orientation of the ureter, and where to cut that suturing. I will show as the videos come down. But these things are very important. The orientation of the ureter, the cutting of the PUJ, all these things have very importance, and you should practice this. Strongly recommended to on a chicken pulpus. I'll just forward this video. So once this anterior layer is done, a digestant is usually kept, but in this case, there is chicken don't need to put a digestant. So once you are done, you will have more confidence, and try 2 or 3 times, and you should be able to do it. And ultimately, you can eat the chicken at the end of the day also. So I immediately came back from Nadiad, and I thought, ki, okay, we will do our first pyeloplasty. And my first pyeloplasty took hardly 4 hours, and it was done very nicely. And it was an crossing vessels. I dissected the crossing vessel successfully, and did the pyeloplasty anterior to the vessel. So on the everybody in the people were quite impressed. Ki, we could complete it in within good amount of time. I will show you certain cases. So this is one of the simple pyeloplasty is quite distended pelvis, and you can see that some tissue is crossing the PUJ. I thought it is crossing vessel, however, it was not. So see how the dissection of the pelvis and ureter goes. So important thing is that in your dissection in pyeloplasty, you should try to use harmonic scalpel. If you use cautery, then lateral current of the cautery might spread and cause problems in the vascularity of the ureter. You should not dissect the ureter more than 4 to 5 centimeters, so that the vascularity of the ureter is always maintained. You see that the edges are bleeding, and once you get the orientation, this is the right side pyeloplasty. So pull the pelvis, start the cut from the pelvis, get the oriented. Proper dissection of pelvis anteriorly and posteriorly is very important. And once you take a cut, this pelvis will retract. So keep an eye on the where you are cutting and how it is going. So if you can see, I'm cutting right pyeloplasty for a right-handed person is easy because the scissor comes from the right side, and all your cutting and suturing happens in one line. So, so this is how a cut is taken. A pelvis, external pelvis is cut, and it is gone. Extra pelvis is cut. So once the scissors have to be very sharp. So what I showed just now was the scissor was not cutting, so I changed the scissor, and now see it is. Then after changing the scissors, it was easy to cut. Because when you go through the ureter, the sharp cut is very important. If the scissor is not sharply cutting, it will cause problems. So get the yourself oriented towards where the medial surface of the ureter is, and sometimes keeping a small tissue will also help you orientation and spatulation of the ureter. And always think, ki, where will be my future PUJ? how I am going to suture, and accordingly take the cuts. Always undercut. You can always cut more at a later time. However, if you cut more, then it will be difficult sometimes. So only this much tissue is remaining. So after cutting, see, complete dismemberment is there. So first stitch which I take is from outside to in the pelvis. I always do an RGP and keep the ureteric catheter in the mid ureteric level. So whenever such problem occurs, I can push some saline and this view becomes quite clear. And my needle can go easily from inside to out in a ureter. Now, when your needle comes from outside to in a ureter, the problem is that sometimes it might inadvertently take the posterior wall or mucosa of the posterior wall, and then the pyeloplasty is an instant failure. So it has to be very important you go from inside to out through the ureter for the first stitch of the angle stitch. Then after this stitch is taken, the another you take the needle in the proper orientation, and then you can do a continuous suturing from as per your ease, from pelvis inside out to ureter outside in. And the thing is that you should be inside, you take the full thickness of the ureter, and it should be close to the wall, not too much from the center. There should be gap available for the urine to move, especially when the near the angle. And there should be a distance around 1.5 to 2 millimeters in between the two sutures. And this should be hardly 1 millimeter away from the edge of the ureteric mucosa. So this mucosa to mucosa anastomosis is done in a continuous fashion. Once this anastomosis of one wall is complete, then I put the digestant. I put the wire first, and after the wire goes into the bladder, I put methylene blue inside the bladder. And once the wire is out, you can see the methylene blue coming out of the digestant tip, and it makes the field a bit blue. But you are confirmed that the lower end of digestant is always in the bladder, and then you can put the stent into the pelvis. Now, once this stent is put, then you have to close the entry wall. Now, that is quite easy once this stent is in place. Now, you can see the mark of the 26 centimeter, and you just hold the previous angle stitch and take a stitch from outside in to inside out. The DJ stent will help prevent the suture of the posterior wall. And once this suture is taken, angle suture, you just tie the knot and then continue the suture towards the another end. Okay. In the first initial period, the accuracy is much more important than speed in a pyeloplasty. Somebody says, I can do pyeloplasty in 15 minutes, 20 minutes. It's okay, fine. But accuracy is more important. Your suture should be perfect. It should be a watertight anastomosis so that you can sleep comfortably. I put stent as well as drain, so there is minimal headache. And this pyeloplasty is a surgery in which there are very few chances that it is going to fail. Now, once this urine leaks, it will cause fibrosis and again problems. So, to avoid all this fibrosis, this watertight suture and keeping the catheter for at least 48 hours so that all these things seals is important. Now, when these sutures are taken continuous, you can see that the watertight anastomosis will easily happen. And at the end of the surgery of all this, just given wash is given, and the pelvis remains collapsed because the anastomosis is wide and continuous. There is a digestant, and you can see that the anastomosis is very well done, and there is no any gap for any leakage of urine. A small drain is kept, and usually these patients go home on the third day once the catheter is out. First, I remove the catheter. So whenever this kidney system is a low pressure system, the renal pressure hardly go beyond 5 to 7 centimeters of water. But once you put a digestant, The voiding pressures are directly transmitted to the kidney. So your anastomosis should be such good that whenever the patient is started voiding, and even if the intrarenal pressure is increased, there should be no leak. So after 24 to 48, after 48 hours, I remove the Foley's catheter first, ask the patient to urinate, and check if the drain is increasing or is there any pain or anything. If that is not there, if the drain still remains zero, then the drain is removed, and then patient goes home. So these are some of the difficult pyeloplasty which I have encountered. Now see this on CT scan, it looks very easy. So this is quite extra renal pelvis, but the parenchyma is thick in the medial end. Okay. So initially it looks ki, "Arey, we were able to do this pyeloplasty easily," but see what happened. So this is the DTPS scan where the function is 27%. The red is the kidney graph. It is gradually increasing, and this is the another kidney graph which is decreasing. So this is an obstructed system. So when I went inside, this was the picture. Now let me tell you, these are intraoperative surprises. I was not able to separate the pelvis, not able to dissect it posteriorly. There was only a small gap in between this artery and this was the vein, and in between artery and this second vein which was lower polar vein, this is the gonadal, you can see, and this is the ureter which is toughly adherent to the lower pole and the pelvis, and it is simply unable to dissect the pelvis properly. So I took a cut in the upper end and decided that I will cut the pelvis and suture it here. So after pulling, you can see the amount of fibrosis which is present. uh, it does. I don't know why this fibrosis so much occurred, but the problem was that this ureter was also very difficult to dissect. The lower ureter means upper ureter looks good below the pujae. However, this pujae part was very fibrous, very tough adhesions, not able to dissect from anywhere. And however, gradually I dissected. Then I found out the internal lining of the pujae. Then this fibrous part of the ureter was gone. Now I need to spatulate this end and I separate it from the surrounding fibrosis. Sometimes all these tubular structures are so that you might cut some of the vessels also. So you need to be careful what you are cutting. Whenever there is fibrosis and dissection, be prepared for open surgery immediately anytime. However, after cutting all this tissue, I started spatulation of the ureter. See, so I got the hole. I spatulated the ureter. I could easily spatulate it. But then I realized that after spatulation, there is a rent in the lower ureter below the spatulation from where the urine can leak. So, so this is the quite well spatulated ureter, and this rent was there below the ureter which was spatulated. So I thought, okay, I will just suture. Now look at these things. Now this I have learned in the hard way that the ureter is quite adherent. It was quite stripped off of the essential vascular supply. It is looking quite pale. There is no active bleeding, and while the fat is still stuck to the ureter. And when I was trying to do this suturing of this pujae, there was so much stretch कि it got cut through. बोला अरे ये तो there is a lot of stretch. So I thought कि okay, now there is the next option is you should not dissect the ureter more. We have to bring the kidney down. So after doing the renal descensus, I was able to do the anastomosis, and there was a little bit of stretch. You can see that the lower pole of the kidney is stretching this ureter. This ureter is quite denuded, and I was able to ultimately do the pyeloplasty laparoscopically. But what happened? After this is the posterior layer, I did the anterior layer. Now what happened ultimately? At the time of suture removal, this is the RGP. I thought it was a difficult case, better do the RGP. This is the RGP. Operated dilated deal here, then a very narrow streak, pyeloplasty failed. So usko, then I put a PCN, and then we gave some time for that inflammation to recover. Then ultimately, I did an open ureterocalicoscopy in this case. So you can see the lower pole of parenchyma, and you can see this is the mucosa of the lower pole, and this is the ureter which is coming easily and which will be closed like here. This is the posterior layer which we are taking. Now, shortly we'll go for the anterior layer. So methylene blue was injected into the system, and for the identification of the mucosa, then a nice chunk of lower pole was cut, and ultimately I had done open uh, ureterocalicoscopy. So this is the RGP at the time of stent removal. I kept the PC until the last time, and you can see that the function is increased, and there is a gradual downslope. However, due to poor function, it is a non-obstructed drainage. So sometimes you have to do all these learn the hard way that the pyeloplasties can fail. First, I thought it is a simple pyeloplasty. I have done 50 hundreds of pyeloplasty. I will be able to do it. But intraoperative surprises you should always be prepared for. And for every pyeloplasty, you have to tell that there will be a chance of failure, which I never know what is going to happen inside, and prime the patient accordingly. So the when the patient is already informed that beforehand, even if you immediately talk to the patient after the surgery that it was a very difficult surgery, there are chances of failure of pyeloplasty, but whatever is the failure, we will take care of it. No need to worry. The patient will have confidence. That is why they came second time to get the ureterocalicoscopy done from me only. And otherwise, once the pyeloplasty fails, the 100% patient in today's world will go to some another surgeon for getting the things done. So मैं बोला कि अरे यार this laparoscopic I don't think I think robotic pyeloplasty will have a lesser chance of problem. So I think we should today is the era of robotic surgery. So we should learn robotic surgery also. So our Jupiter Hospital got that Da Vinci robot. So I got trained on the console. Before doing any robotic surgery, it is very important that you use the simulator to train the mind and do the hand-eye coordination. I thought I am doing laparoscopically, it will be easier robotically. But however, when I sat on the robotic console and when I was doing all the exercises, I really felt I was not able to go beyond level exercises 1 and 2. There are exercises levels up to 5, and every movement is tracked in this robot. Every movement you make, the hand movement, it is tracked. Your touch to any another instrument is tracked. All these errors are calculated, and at the end of the time, end of the exercise, they will give you an whole mark sheet. You have failed in this, you are succeeded in this, so where is the scope of improvement? And that simulated training is very important. So let me tell you how this simulated training works. You are controlling a remote control, it is connected, and your movements are tracked. So if you touch the glass, it will cause an error. If your movement does anything, it will cause an error. So there is a time bound also. You should do the things within the stipulated time. If you're taking too much long, then also it is not accepted and you will get the less marks. So this increases your precision of movements, and this robotic console training is very important before doing any robotic surgery. So it trains your hand and eye and feet for doing all those activities. So after doing multiple exercises, they give us an task complete, and at the end of their complete, they will give you how much marks I got. So you can see that I have got 100 marks. So there is no negative point, economy of motion, everything. So overall score. So I got trained so hard that I got 100 and 100 and almost all the exercises. That is why when I got confident, okay, now I will be able to do the pyeloplasty robotic surgery also. So I also got a certificate requirement from Bangalore. I went to Raghunath sir because it is very high volume robotic center. They are daily doing 3 or 4 robotic surgeries. They have 2 robots there in one center. They are mostly doing uro-oncology, but I got good experience there. So one of the pyeloplasties was this one, robotic. You can see there is a stone plus a long pelvis. So I thought suturing will be very easy robotically. So I advised robotic. Patient was also ready. And after removal of stone, it is a very shiny and hard stone. This stone was removed, and after that you can see the movements. So the suture, even though it is a left pyeloplasty, I am doing with the right hand. You can orient the needle in any direction, and that becomes a bit easy for suturing. So continuous suturing is and intermittent suturing is also good in robotic cases. And uh, you should always, whenever opportunity is there, always try for getting robotic surgery, because I feel for suturing, it is much more easier to do it robotically than laparoscopically. However, once your experience grows, you will be able to give the same results laparoscopically versus robotically also. But once you have Mercedes, then why do you want to go with Maruti? Even if you have 2 cars and you go from point A to point B in both the cars. Anyway, so this is the robotic suturing. You can see the suturing is very intuitive, as if you are doing in open surgery, and it is a 3D vision. So the learning curve is better easy. The camera is in your control only. So you don't need to tell the assistant, show me here, show me there. You think, and automatically your hand and foot and eye coordination works to move the camera in that direction. Then I would always suggest, don't go for the looks, go for the function. This patient came with an this kind of picture. So I thought, ki first you get the DTPS scan done. So this was the DTPS scan. Both the these were downloading, this downsloping, and this was done in 2024. Patient was asymptomatic. So I told them, ki, let's not operate at this time. Let us observe, keep on observing, do regular DTPA after every 1 year, and we will see how you go. After 2 or 3 years, she came with this DTPA. There is a huge difference. You can see that there is a downsloping in left side. The system is non-obstructed. But as the time progressed, the patient got obstruction. Then we decided to do robotic pyeloplasty in this case. Now what happens? This is the picture. Very narrow ureter, whole length, very long length of PUJ. And it was a downponing, but you can see this much part is not expanding in an PUJ. Uh, So I thought, ki, okay, we'll do this robotics. So instead, I took this cut, dissected the PUJ, then this cutting of that pelvic junction is similar in laparoscopy and robotic. The principles are same, only the instruments are different. So you can see that I'm excising a bit more of the pelvis, keeping the inferior end of the pelvis intact so that it can go down. And this, once understanding how much the pelvis is retracting, I am cutting the excess. I can see how much the pelvis, lower end of pelvis and the future PUJ, where it will be. And accordingly, I will decide, okay, I will stop here. Okay. So once the ureter is get, that is the lateral surface of ureter is oriented. And then you have to take the ureteric cut. So understanding this orientation and cutting in the lateral way is very important. And you can see that it is this. So how much to cut? So I thought, ki, this is the narrow part. You can see the vertical rugae. This is definitely the pelvis part. And you can clearly understand whenever there is an PUJ obstruction, whenever you are cutting the vertical rugae, you will be able to see. and identify the normal ureter. So once this narrow part is gone, you check how much the ureter can go up. You check how much the pelvis can come down, and accordingly, if you want to increase the cut, then you can increase a bit more. So in spite of doing wide spatulation, you can see the peristalsis. While peristalsis, the ureter walls are moving away. That means this is quite good. A normal ureter has come. You always do an RGP and find out the length so that it becomes easy. After this pyeloplasty, after removal of stent during RGP, this was the picture. Now this still feels like as if it is an puja obstruction. However, while pushing the die was going up easily. While coming down, it was getting lighter. So I thought, ki, let us wait before telling her ki, we will do a DTPS scan and decide what to do. So this is the DTPS scan. So immediately doing RGP at the time of stent removal, probably due to edema or something, this picture came. However, when I did the DT, patient was asymptomatic. Patient was not having pain or fever after removal of stent. So I thought, ki, okay, then you can go home and we will do the DTPA after 1 month and see. So this is the 1 month DTPA. You can see that it is a downsloping, and I thank God ki okay. Now this narrow pelvis is also done. Thank you very much. I think I have given an extensive presentation. You can enjoy a view of RRS in which how the urine comes out of the tip of the papilla. So I always, this is called as reverse waterfall. So this kidney is filled with dye during RRS, and see how the urine comes in the thin continuous stream from the tip of papillae moving outwards and upwards because it is lighter than the dye which is present, and it comes from the tip of papillae. Thank you, sir.
Thank
Sir,
you.
your expert comments.
Yeah, very fantastic presentation.
Hmm.
The best thing I like always is your best part of that cut through. See,
Hmm.
you have
Hmm.
shown when it is cut through. So my personal opinion is you have covered everything.
Hmm.
Um, the important aspects I wanted to add are uh, any anastomosis which you have done dismembered in the ureter, if you do nephrostogram or RGP, it looks less prominent when compared to the normal ureter, and pelvis don't get disheartened
Hmm.
any time in life. So it looks like the same before. The best assessment I feel is not having pain, not having fever after the stent removal, and my personal opinion. It's a debatable. You express your views, I am expressing my views. I am also doing for 22 years, you are also doing for 20 years. The drainage pattern, if it improves, you should be happy. You said, thank God. I
Yeah.
also say the same thing. So you are very honest. So lack of pain, lack of fever, and drainage, I will write on the paper every pyeloplasty that these may be looked than the dilatation and dilatation. And
Yes.
the benefit of doubt, if the pyeloplasty function is good, don't operate.
Yes.
Because if the function decreases, even though it is overestimated function, over a period of time, if the function is not deteriorating, at least 2 scans you should have. That
Hmm.
is theory. As far as practical is concerned, when cutting the pelvis, as you have shown, go as low as possible, preserving the pelvis at the PUJ.
Hmm.
Don't cut horizontally towards the kidney and lose the important flap going down in the pelvis.
Yeah.
Pelvis towards the lower pole of the kidney is highly precious in PUJ. Go vertically down just above the PUJ, you finish it. Just above the abnormal PUJ, you finish it. No problem. because width will manage, blood supply will manage. But if you cut horizontally, ureter should not come to pelvis is my always say. Ureter should never be dissected.
Yes.
Ureter should be there only. All the tissue on the ureter should be there only. Pelvis can be dragged, or the best way you have shown is immediately intragerotal, right on the renal surface. Everybody can dissect the kidney and renal descensus can be done. You have shown that nicely. You have shown that nicely. Even recently, I have shown in ureterochelicostomy. After the anastomosis, I was feeling that little tautness is there. No, I said I will do PCN. I will do renal descensus. PCN, if you give renal descensus and PCN, you will be safe in the post-op. However, PCN will not ensure that your results will be good. If it has to fail, it will fail. And fourth point, never use energy source around the ureter which you are going to suture. Let it bleed. It cannot be aorta. It cannot be external iliac artery. It cannot be internal carotid artery. So liberally cut with fat without going to the adventitia of the ureter. Bunch of the ureter you take. Entire bunch. Sometimes I take in redo along with psoas fascia. But
Okay.
I want to skeletonize, entire bunch will be there. My aim while suturing is the fat will come in between. So I trim only 2 to 3 mm. Like intestine, we do mesentery. When you are suturing the angle mesentery, 2-3 millimeters, if you separate nicely, suture will come. For that, you need not separate kilometer. This is really real because dismemberment in urethra has gone. Dismemberment in urethra has gone. Nobody is allowing to dismember. They are telling that except in traumatic cases. Where same in the ureter, dismembering means every RBC has to find its own new vessel between both of them. The chances of fibrosis is more. However, widely you anastomose, it is cut. Cut is, if the complete cut of the hand or anything, it becomes a plastic surgery so that the vessels have to. This is not a graft. It is a flap.
Yes.
Flap, both the sides blood supply is required. So
Yes.
blood supply to the pelvis will anyway come. It's a tough structure. But ureter, upper end, the blood, especially even if you don't separate the ureter at all. Just, in fact, my teaching in my hospital is recently Soundarya has done in Safdarjung hospital. Half centimeter of the ureter also she did not mobilize. I say ureter, let it be there, plastered to the pelvis, cut the pelvis, spatulate, that's all. No hanging of the ureter in the air. That is our feeling that ureter will come. Ureter hardly 1 centimeter also will not come. Immediately renal descensus. I'm so happy that you have shown renal descensus. I'm so happy that you have shown the this thing not. And one more thing, even you are taking first bite. If bite after tightening 1 to 2 times is loosening, that means it may fail. You remember this. A crude index that you put perfect square knot with a surgical knot. Surgical knot is 2 times throwing. Square knot is opposite and pull. If you leave it and suddenly it is departing, that means renal descensus, you do it. So lesson is in a difficult cases, lungs, for example, last case you have shown. After that you have cut, you know why you have cut, I am thinking, still you feel that the ureter is small, the area which you are seeing. That's why you have cut a little more spatulation. That is very good. But he also told that he is experienced. Bhalerao today, I also did not see his principles, but his experience is committed. This is what required in reconstructive surgery. Don't attempt casually pyeloplasty. Take the help of the senior up to dissection. Even I am telling dissection also. Don't never use cautery. Point coagulation with the scissor is very best than harmonic. Harmonic, what happens? Without our eyes seeing, kilometers will be coagulated. The surrounding vessels will be coagulated. So ureteric blood supply from the lower pole only you think. I am thinking some of the blood supply from the lower pole of the kidney also should give the upper. That you should not disrupt. Completely separating the lower pole from the ureter is of no use. Last point in my Chandigarh training, anteriorly malrotated, posteriorly malrotated, medial lateral. Normally, PUJ is ureter opens medially high. It is the easiest case. Most difficult case is ureter opens posteriorly laterally behind the kidney. That should be ideally done retroperitoneoscopy. In that case, my teacher used to say, let any direction the ureter be. Cut. Where do you cut the ureter first in difficult cases is just above the abnormal PUJO. That tissue will not be used for the pyeloplasty. Wherever the ureter is inserting, just above that pelvis you cut and empty. By emptying the, normally we empty exactly at this spatulation where we have to do. That may be confusing. So if you wanted to, even he says, if you don't know, you aspirate all by needle. Once pelvis collapses intact, then wherever the ureter comes nearer to the pelvis, that is a dependent area. Where whatever medial, lateral, this is my favorite thing. Dr. Goswami used to tell this. Very useful in ectopic kidney. Ectopic kidney pelvis, very useful in posterior malrotation, in which case sometimes we flip the entire kidney because pelvis is posterior structure. These are the difficulty cases, but he has shown perfectly his complication. This is a big subject, but remember it is a bread and butter for urologist. When you do it 100% so that, as he said, 5% failures can occur, but as much as possible explain before only. CT properly read, IBP properly read, DTPA scan properly read. Then if you select, if I have to select 20 to 30% function, severe obstruction, I will easily select. If it is more than 40% function and it is equivocal, I will wait now. Varicocele is one surgery, PUJ obstruction is one surgery. If the postoperative varicocele is grade 3 and PUJ is again grade 3, patient will always doubt you. Patient will, however good you are, however senior you are, however famous you are, they will doubt you. So these things keep in mind. I think I am adding only few points. I must really appreciate Bhalerao. You must give more talks in pure urology on your favorite subjects. You have really collected the material. I am really happy for that ureterocalicostomy, the way it was looking in the RGP. It will definitely succeed. And kidney is saved in that case with good parenchyma. Thank you very much for your talk.
Thank you, sir. Thank you very much.